Hello everyone, my name is Sydney Gipson from Maryville University, and today I will be presenting my Doctor of Nursing Practice project, which is titled, Does Initiation of Skin-to-Skin Contact in the Operating Room Help Initiate Breastfeeding? This project focuses on improving early breastfeeding outcomes by introducing skin-to-skin contact immediately after cesarean delivery in an operating room setting. The committee that I was fortunate enough to work with included my chair, Dr. Pauline Foy, my second reader, who was Dr. Stegman, and my community member, who was wonderful and so helpful in this project, was Cecilia Bates. So the background and significance of this. The Quality Improvement Project evaluated whether implementing skin-to-skin contact in the operating room following a C-section delivery improved time to breastfeeding initiation. This is significant to practice for many different reasons, but I'll name off a few. Early initiation of breastfeeding is a critical component in newborn health and maternal-infant bonding. Breastfeeding provides essential nutrients for a newborn, like immune protection and long-term benefits for infants. It also improves maternal outcomes in many different ways. One of the most effective strategies to promote early breastfeeding is immediate skin-to-skin contact, which supports thermoregulation, physiologic stability, and early feeding behaviors. However, despite all of this evidence, implementation of skin-to-skin contact still remains inconsistent following C-section deliveries. At my project site, baseline data did show a median breastfeeding time initiation after C-section delivery was 64 minutes. Inconsistent implementation and documentation of skin-to-skin contact, and no standardized protocol in the operating room. This gap highlighted missed opportunities that would support early maternal-infant bonding and promoting breastfeeding initiation. And now we'll go over our review of literature. So, evidence supports skin-to-skin immediately after birth. However, our implementation in the OR still remains inconsistent. The literature consistently supports several key findings. So, evidence shows that skin-to-skin contact improves breastfeeding initiation and duration. We call this the hour after birth the golden hour. And it's known as that because it's important to support bonding, but then it also supports reflexes like the rooting and latching reflex. So it's important that we do that. Cesarean delivery is associated with delayed breastfeeding initiation, and we see this, and this ties into a huge portion of this study, and is why the research is so important here. There are different factors that can interfere with skin-to-skin and breastfeeding initiation and C-sections, or during C-sections. So anesthesia personnel, post-operative pain control, separation of mom and baby for recovery time are just a few of those reasons that can hinder that. And these disruptions can delay the first feeding and can have negative outcomes on maternal milk production and maternal confidence in breastfeeding. Early skin-to-skin contact promotes neonatal thermoregulation and bonding. Skin-to-skin helps regulate the newborn's temperature, heart rate, and respiratory rate, and more efficiently than a traditional warming method. The mother's body acts as a natural incubator, and additionally, skin-to-skin contact enhances maternal-infant bonding by increasing oxytocin release, which supports emotional connection, reduces maternal stress, encourages nurturing behaviors, and helps with bleeding also. Barriers that are in the OR do include workflow, sterility concerns, and staff training. So maintaining a sterile field during a cesarean procedure, as well as the lack of standardized protocols and staff education on how safely to facilitate skin-to-skin contact in the environment, can be concerning in a fast-paced OR room, crew, all of those things. Interdisciplinary collaboration is essential for successful implementation. Clear communication, role delineation, and then shared goals are key factors that help overcome those barriers and support the practice change. Overall, the literature does demonstrate that skin-to-skin is evidence-based but underutilized in a surgical setting. While the strong evidence supports skin-to-skin as a best practice, it's still not consistently implemented in OR or surgical room deliveries. So my framework, the project was guided by the Iowa model of evidence-based practice. The Iowa model is designed to help clinicians identify practice problems, evaluate current evidence, and then implement that evidence-based practice change into a structured and systematic way. In this project, the identified problem was inconsistent implementation of skin-to-skin contact in the operating room following a C-section delivery. The model guided the process by first supporting a review of current evidence, which strongly demonstrates that skin-to-skin contact improves breastfeeding initiation and maternal infant outcomes, which we've talked about numerously now. Next, it informed the development and implementation of evidence-based protocols to facilitate skin-to-skin contact in an operating room. The model also emphasizes interdisciplinary collaboration, which was a key component in this project, involving nursing staff members, obstetric providers, anesthesia personnel, and the surgical OR staff, crew, and team. Finally, the Iowa model guided the evaluation phase, where outcomes were measured through comparison of the pre- and post-intervention groups and the data collected in those. The framework ensured that the project was systematic, evidence-based, and focused on a sustainable practice change. So we'll go over our designs and methods now, and the project utilized a quality improvement design on pre- and post-intervention approach. The design was selected because it allows for evaluation of practice change in a real-world clinical setting by comparing outcomes from a pre- and post-implementation of the intervention, which was skin-to-skin in the OR. A retrospective chart review of electronic health records was conducted to collect the data on the eligible patients. The project took place in a rural hospital in the United States and included the operating room, post-anesthesia care unit, labor and delivery, recovery, and postpartum unit. The total sample included 71 participants, with 36 in a pre-intervention group and 35 in the post-intervention group. Inclusion criteria consisted of singleton delivery, C-sections, medically stable mother-infant dyads, and patients who intended to breastfeed. The intervention involved implementing skin-to-skin contact in the operating room immediately following the C-section delivery when clinically appropriate. We didn't want to force mothers to do skin-to-skin or breastfeed, so those are the questions that were asked to ensure that there was no wrongdoings for patients. This was supported by staff education, workflow adjustments, and interdisciplinary collaboration among nursing staff, OB providers, and anesthesia personnel. The primary outcome measured was the time to breastfeeding initiation, defined as the number of minutes from the initiation of skin-to-skin contact to the first documented breastfeed attempt. For data analysis, the Shapiro-Wilks test was used to assess normality, which indicated that the data were not normally distributed. Therefore, a parametric Mann-Whitney U test, was selected to compare the pre- and post-intervention groups. Statistic significance was set at a p-value of less than 0.05. Overall, the methodology allowed for evaluation of whether implementing skin-to-skin contact in the operating room improved the timeliness of breastfeeding initiation. So the sample, which we kind of talked about, I know in the last slide, it included the 71 C-section deliveries from my facility, and then more on the inclusion criteria that we can talk about would be that they were singleton cesarean deliveries, We had a medically stable mother and newborn, and then the intent to breastfeed. Additionally, our participants were over the age of 18 years old, and the mother, again, medically stable for skin to skin, and then wanted to do skin to skin. We excluded those who were under 18, had multiple gestational pregnancies, and any maternal or neonatal complications. So that kind of included mom was put to sleep, the newborn had to be resuscitated in any kind of way, anything that would hinder that immediate skin to skin. Inferential statistics guided by a retrospective chart review was done to evaluate the impact of skin-to-skin contact in the OR following a C-section on breastfeeding initiation rates. The data was drawn from the electronic medical records and abstracted into a secure data collection sheet that was created just for this project. The dates for the data collection were from October 1st, 2023, and then went to March 31st of 2024. They represented both the pre- and post-intervention periods. Our pre-intervention period was from October to December, and then from January to March was our post-intervention period. The final group size was determined on the inclusion criteria and the data available. All the data was de-identified before putting into the collection sheet that was made for the project. So our data analysis. So we talked about the descriptive and inferential statistics that were used for analyze the data. Allowing both a summary of the sample characteristics in comparison between the two groups. So to determine the appropriate statistical test, the project team first assessed normality using the Shapiro-Wilks test, which we talked about, a little bit before. And we also talked about that the results indicated that the data were not normally distributed, which guided the selection of a non-parametric approach. Because of this, the Mann-Whitney U-test was utilized, which is appropriate for comparing two independent groups when normal distribution assumptions are not met. The primary outcome measured was the time to breastfeeding initiation, comparing the pre-intervention and the post-intervention groups following the implementation of skin-to-skin contact in the operating room. While the results did not reach statistical significance, there was a clear trend towards improved outcomes of the post-intervention group, suggesting that infants in the post-intervention group initiated breastfeeding sooner. Although statistical significance wasn't achieved, the findings suggest potential clinical benefit, and we can't ignore that. And this highlights the importance of considering both statistical and clinical significance when evaluating practice changes, particularly in a quality improvement project with smaller sample sizes, which is exactly what I had. And we'll talk about the results here. So our results demonstrated that the time to breastfeeding initiation did decrease following implementation. The pre-intervention time was 64 minutes, where the post-intervention time was 45 minutes. And I have the graph there to show the difference. However, the difference was not statistically significant, but we can't not note that there was a 19-minute reduction time in our post-intervention group. A higher percentage of mothers initiated breastfeeding earlier in our post-intervention group. And again, added the graph so that you could see, even though it's a subtle change, there's still a change. These findings do suggest that implementing skin-to-skin contact in the OR does have a positive impact on early breastfeeding outcomes. And although it's not statistically significant, the reduction does suggest potential clinical improvements. And importantly, it shows that skin-to-skin contact was successfully implemented. There were no adverse events that occurred. Workflow challenges were minimal and manageable. And these findings do support the feasibility and safety of this intervention, while also improving patient satisfaction outcomes. The limitations, so with any quality improvement project, there are several limitations that should be considered when interpreting findings. Recognizing these limitations is important for understanding both the strengths and the context of the results. So several limitations that I did consider and that we should consider would be the smaller sample size reduces the study's statistical power, limiting the ability to detect statistical significance and even if a true effect exists. I just had a single site setting, so that can limit my findings instead of having multiple sites. My limited time frame, so I only did the 3 months pre and then 3 months post, so 6 months altogether. But this may not have allowed significant time for a full implementation of the intervention for the staff to become completely comfortable with incorporating skin-to-skin contact into the OR. Variability in clinical factors and documentation. So the study may not have been powered to detect the small differences. These factors may have influenced the ability to detect the significance. And in other words, even if the intervention had a meaningful effect, the sample size might not have been large enough to show that change or that significance. So overall, these limitations may have influenced the ability to see that, but we also have to take into account that they did highlight important opportunities for future research and the project expansion. So now our discussion, which is our lengthy one probably. In this section, I will interpret the project findings and discuss how they relate to existing evidence of clinical practice. So first, the findings of the project are consistent with existing literature demonstrating that early skin-to-skin contact improves breastfeeding initiation. Numerous studies have shown that when skin-to-skin contact is initiated immediately after birth, infants are more likely to begin breastfeeding and have a higher success rate. We see this project adds to the body of evidence by demonstrating similar trends specifically within the operating room setting following a C-section delivery. In this project, the implementation of skin-to-skin contact in the operating room was associated with a reduction of time to breastfeeding initiation. And although, again, not statistically significant, that wasn't achieved, the observation decreased in the time, so like our 19-minute reduction. Intervention, it did have a positive effect, and we can't sell that short. So this indicates that even within the constraints of a surgical environment, meaningful improvements in care processes are possible. One other important thing that we can note is that skin-to-skin is feasible in the operating room setting, which we talked about a little bit before, but this is significant because the OR is often viewed as a challenging environment to implement patient-centered interventions due to sterility, workflow, and competing priorities. However, this project proves that it is possible and safely to put into practice. I think some of our biggest challenges that we saw with this was probably from anesthesia, and just because they wanted us out of their way because they were used to it. But over time, it did improve. Interdisciplinary collaboration was key, a key component of this implementation, and it did improve. It involved nursing staff, the OB providers, anesthesia, and OR crew, because they're all essential to both patient safety and adhering to the skin-to-skin practices while keeping the sterile environment and keeping everything going. The project also demonstrates that practice change is achievable with education and structured implementation. Providing staff with education, clear protocols, and defined roles help with reducing these barriers to set up successful and consistency in practice. So the results answer the project question, showing that the implementation of skin-to-skin was associated with a reduced time to breastfeeding initiation, and again, Not statistically significant, but we do see the trend that supports effectiveness and intervention that aligns with our patient-based outcome. So again, clinical significance, we can see the decreased time to breastfeeding initiation from skin to skin, which is clinically meaningful. Early breastfeeding initiation is associated with improved neonatal outcomes, and we talked about all of those great things that come with it. So skin to skin in the OR is a low-risk, high-benefit intervention. So these findings should be supported and integrated into cesarean delivery practices because it is meaningful, it is feasible, and it improves breastfeeding outcomes. So implications for practice. Findings support the integration of skin-to-skin into standard delivery workflows. The nurses play a critical role in patient outcomes, which would be initiating the skin-to-skin contact post-delivery, advocating for mothers, so infant bonding in the OR setting, even if you get pushback from anesthesia or someone else. Also educating the surgical team members on skin-to-skin benefits, which was very important in ours because we are a baby nurse. They're more mom nurse at my facility. So we had to make sure that they were included in that. Earlier breastfeeding initiation may contribute to improved breastfeeding success and duration, enhanced maternal and infant bonding, increased patient satisfaction, and the implementation of skin-to-skin in the OR represents a meaningful opportunity for nursing-driven practice change to improve maternal and neonatal outcomes. In our conclusion, skin-to-skin contact in the operating room is feasible and sustainable. It may improve the timeliness of breastfeeding initiation, which is huge, and the benefit of the newborn and the mother, which is fabulous. While statistical significance was not achieved, clinical significance is still important and very beneficial. If repeated, extended timeframes, increasing my sample size, and strengthening the data collection consistency would be done. Future recommendations include standardized protocols, ongoing staff education, and continued quality monitoring. This DNP program has strengthened my ability to lead change, evaluate evidence, and improve patient outcomes. It has pushed me to do better and to think about future outcomes and to support all staff. It's prepared me to be a strong advocate for evidence-based practice in newborn and maternal care. And these are the references that I used throughout the project. I would be happy to discuss them any further. Thank you so much for your time. Thank you for listening. I hope you all learned something along the way.